Good afternoon, everybody. Welcome back to I think this is day 7 of the NCHV Annual Conference Virtual Edition. We don't usually go past day 3 when we're in person, so thank you all for coming back again today. I'm Cindy Borden. I'm Director of Training and Technical Assistance for NCHV, and we're thrilled to have you. This is session SP1, Connecting the Dots to Serve the Aging Veteran Population, and we've got some just fabulous experts to talk about this really important population that we want to be serving. We probably shouldn't call it a special population. It's more of a subpopulation of veterans, but it is a very important and growing subpopulation, and you'll hear all about that in today's session. Before I hand things over to Amy Fairweather, our moderator for today, just a couple of reminders about the logistics of GoToWebinar. You have all come in and you are muted, and you will be muted for the entire session, but we really do want your questions. So please, as they come up, just type them into that question box and submit them, and we'll have some time at the end of the session for questions. So with that, I'm going to hand things over to Amy.
All right, great. Well, thank you everyone for joining us today for this session. We can go on to the next slide. There's a little delay. And good morning to folks who are in California like we are. So we've got John Natchison, Callista Neighbors, and Michael Blecker, and I'll be introducing them more formally at the beginning of their session. And we go on to the next slide to talk about what we're going to get into today. I think, we know that we're facing an aging population with higher needs, so we're going to talk about the unique needs of aging and Vietnam-era veterans, understanding the needs of unsheltered aging veterans, addressing their medical, psychological, and social service support needs, and very importantly, exploring how we need to develop services and address the needs, because we know that we need more. So we want to break out of those boxes and really explore ways to address. So next slide, please. I don't think this next slide will come as a big shock to anyone. As we look at the population, this is the overall population, not just the homeless population, but it's very reflective of what we're looking at. And we can go on to the next slide and talk about why these veterans really need extra attention. We know that they have early risk of death, that they are among the highest in the homeless population, 60% of those using emergency shelters were over 62. They tend to be older than their physical age because of their disabilities and because of experiencing homelessness chronically throughout their lives, and they are the hardest to place. There's a lot of issues, severe medical issues, acute needs, but also cultural issues. Not to mention the problems with funding and building and supporting and staffing the appropriate venues to take care of these veterans. So with that, we're going to move on to our first presenter, John Natchison. Dr. John Natchison is a U.S. Army veteran. He co-founded the Stand Down, the National Stand Down for Homeless Veterans, with Robert Van Kuren in 1988. He is a diplomat on the American Board of Professional Psychology, emeritus at Bayview Hospital, and a former faculty at San Diego State University, and was awarded the Lifetime Achievement Award from NCHV in 2011. So with that, we'll turn it over to John.
Thanks, Amy. There's a simple definition of unsheltered homeless person that to me has powerful implications. Anyone residing in a place not meant for human habitation. Veterans living in poverty are 3 times more likely to become homeless than the general population. African American veterans are especially overrepresented in our homeless population, and we know must be the focus of our resources and programs moving forward. The overall number of homeless veterans in America is decreasing, thanks to the great work of NCHV. The number of elderly vets, however, is steadily increasing. 1/3, as you were, 1/2 of homeless veterans in the United States are over 51 years old and are veterans of the Vietnam War era. 2/3 served in the military for at least 3 years. 1/3 were stationed in a war zone. And I think that, to me, that's important. We're not just talking about, people, losers on the street. These are people that served. They served their country. And 50% of all homeless veterans are age 51 or older. And this is, to me, is staggering, because the research supports the hypothesis that homeless vets have a significantly reduced lifespan and are physically 15 to 20 years older than their chronological age. The Interagency Council on Homelessness reports that the average length of homelessness for a veteran is 6 years, compared with 4 years for non-veterans. This becomes important because the longer you are on the street, the more critical it becomes in terms of developing problems. Homeless vets experience accelerated aging and disproportionately high rates of chronic illnesses and poor health status, nutritional deficits, depleted immune systems, poor dental hygiene, substance abuse dependence, as well as physiological stressors. Serious geriatric conditions in homeless vets were greater than those seen in sheltered adults who were at least 20 years older. So when a person is on the street and they're 50, they can have illnesses and disease that makes them as though they're 70 or 75 or 80. So I'm going to stay with me. I want to read these illnesses just so we're all aware. Cancer, hypertension, coronary artery disease, congestive heart failure, diabetes, stroke, chronic obstructive pulmonary disease, arthritis, HIV/AIDS, hearing and visual impairment, urinary incontinence and falls, mental health issues, PTSD, anxiety, depression, substance use and dependence, dementia, cognitive impairment, sometimes accelerated by head injury, sometimes by alcoholism, need for assistance with activities of daily living, and increased risks of suicide. It's a long list, but it's a description of what's going on out on the street. There are no easy, inexpensive solutions. Our elderly veterans will require complex medical interventions, memory support units, long-term caregiving, and housing with professional staff. According to a government accountability office, many VA contracted nursing homes provide inadequate care at this point, insufficient staff, and an inability to handle special needs, including behavioral issues and dementia. And yet, access to even this minimal kind of care is very unlikely for our unsheltered, elderly homeless veterans. Current services for homeless veterans are mostly a one-size-fits-all approach. As an example, an 80-year-old is not going to benefit from job counseling or unsupported housing. Homeless older vets typically have no income, no savings, funding for their life support, and quality of life must come from other sources. Quality of life means not warehousing. It's not just about, finding an empty building and housing all these folks and hoping for the best. It's kind of like you have to think about a relative, an older relative. What would you want for their quality of life? This can't be solved exclusively by the VA. It's going to take the whole community and private sector partnering, and with the VA, federal, state, local government to meet the needs of our aging homeless veteran population moving forward. Younger returning vets were assisted by the Vietnam generation. And I know I've had a chance to work with a lot of these folks in San Diego, and there's just some wonderful, dedicated people. This is an opportunity, I think, for younger vets to be able to reach back and to be able to help their older brothers and sisters. There's really a need for programs, there's a need for workers, there's a need for people to get out there and go into the bushes and find vets and be able to bring their benefits and resources to them. This won't be solved by adding a few more beds or a few more social workers to existing programs. It's going to require a radical reassessment of priorities and a paradigm shift in how we structure our program and allocate resources. I've spent over 30 years working with our annual stand down program in San Diego, which has the third largest homeless population, veteran population in this county. This past year, under the leadership of Darcy Pavich, Ron Stark, and Marilyn Cornell, we brought in around 700 vets off the street. 67% of them were over 65 years old. 80% of the vets we brought in to our last stand down were 50 years old or older. Vietnam veterans being the largest cohort. To me, these numbers are a major wake-up call, a demand, a call for action. I don't think we can wait for increased funding and new legislation. I was really fortunate back in the early 80s to work with my great friend Robert Van Kuren. We established the first stand down in 1988 and assisted the spread of the homeless veteran mission across this country. Stand down is really a part of the DNA of NCHV. It's part of the lifeblood of this organization, and it grew because it was the right thing to do. I believe that what's needed now is a grassroots effort that begins at the community level, gathers momentum to move the agenda of this aging veteran crisis and make it part of our national homeless agenda. There are literally hundreds of stand downs in this country. I think that the stand downs in a way are like the canary in the coal mine. You go to the stand downs in your area and see what their data is, see what their needs are. And what I want to recommend is that people think about organizing in your community. Each community is different. Each community has different needs, but whether you call it a meeting or a summit or whatever, bring together major players in your community and talk about this issue and look at possible solutions. I think that this has to be done. It has to start at the community level. Again, not waiting for legislation, not waiting for funding, but starting at a base where we can grow a grassroots effort and then bring this and make this national. We're facing a staggering increase in our aging homeless veterans. The numbers aren't going down, the numbers are going up, and they're going to increase as we go. I think that you could call it us a special population, or you could call us the special population of homeless veterans that's just getting older. Whatever it is, we have the resources in this country to make it right. And no veteran who served their country should ever be left to die on the streets of America. Thank you. Amy?
Thank you, John. And I can just tell we're going to have really rich discussion after the presentations. There's so much to talk about. So our next speaker is Callista Neighbors. Callista is a licensed clinical social worker and an advocate for improving veteran care. She's been with the VA in Palo Alto for the last 8 years. She's presently working with the Healthcare for Homeless Veterans team in addition to her role as a coordinated entry specialist. And we'll let Callista take over now.
Thank you. So I started out with this quote. If we can go back one slide. Just sorry. I don't know if you guys can hear me.
Callista?
Yes. Can you guys hear me?
Yes.
Okay. Yeah. Sorry about that. I've lost access to my screen. When something happened with the change, I'm not sure. It's okay. I can pull it up in a different way. No problem.
I can read the quote.
That would be great. And I'll just start from there. I'll get it back. Thank you.
Okay. The quote is, homeless and at-risk veterans need more than just shelter. We must give them the tools to empower themselves and reclaim the self-worth and dignity which comes from occupying a place in the American dream. It is a dream they fought so hard to defend for the rest of us. And that is from Maria Cuomo Cole.
Thank you. So just going on from what John was speaking about, we have this, we can go to the next slide, the ongoing cycle that our veterans go through. And, you know, we see veterans then coming in, we're talking about the multiple acuities and medical decompensation that they may be having. So they come into maybe a homeless shelter or a stand down. And what happens at shelters is they are unable to take care of themselves. And the shelter staff isn't able to give them enough assistance. So sometimes they end up going to the hospital, but we've also seen them end up in jail because they just couldn't take care of themselves on the streets. After that, the veteran is discharged often again from jail maybe, or the hospital back to the homeless shelter. And because they're not getting the right level of assistance to really manage their chronic conditions, we just see them go through these same cycles. Our shelters aren't really set up traditionally to really handle the veteran need. So next slide on scope. HUD defines a geriatric homeless person as one who's over 50 years of age. And we've seen that the studies have shown, we were talking about earlier, that veterans age, especially street homeless veterans, age much, much more rapidly than others. So they will present as 15 to 20 years older. In addition, veteran ages 62 to 74, we're talking about the increase. One of the studies we started looking at just a few years ago said by this year, it would increase from 50% up to 250% of veterans in that age category. And then addition on top of that, we're seeing an increase in health cost. A normal person maybe goes to the hospital between the age of 25 and 51. Every year you see your doctor, maybe costs $15,000. But what we saw at VA Palo Alto when we took a survey of the top 10% of veterans who are experiencing homelessness that were in the geriatric population was an average of $176,000 in our hospital. So we knew something just by that survey alone, like the increase, we are seeing more people and we keep seeing having this same cycle. The next slide about acuity. Our older veterans, we had a study done at the UCSF, and these are the increases that they're seeing. A 39% increase in difficulties completing their activities of daily life, 38% global cognitive impairments, 40% with executive functioning impairment, so really having difficulty managing complex systems. 34% reported falls, 48% were screened positive for incontinence, 45% had visual, and 36% had hearing impairment. And then on top of that, the leading causes of death for all homeless that were 45 years and older, it was heart disease and cancer, but the next was managing these chronic illnesses. Just from the things I've listed off, if you're going in and out of shelters or in and out of street homelessness, and you're having problems with your executive functioning, or you've been falling, and now you're trying to get to hospitals and try to navigate those systems as well, it becomes very difficult. All right. So the new housing model that we were looking for is something different. We needed something in between shelter and where we're at. It's going into nursing home. It's not always right. There was something needed. We needed an intervention. We needed something that could assist with basic ADLs or medication reminders and nursing monitoring. And we also have medical respite shelters, which help, but those are for short term. These are chronic, ongoing conditions. So we needed something that was more for long term, not I broke my leg and I need a couple of weeks to recover. These are ongoing conditions and they may actually get worse because they are chronic. So we also need something very similar to maybe a licensed boarding care, but shelters aren't licensed care providers. Okay, next slide. And so what should this program look like? What does it look like? We needed something with medical oversight. We needed nutrition programs to really help those chronic conditions. I just know from seeing years of people being on dialysis and having high blood pressure and things like that, if they're not eating properly, those conditions just continue to get worse. And we needed coordinated care with mental health and medical providers. And we also needed someone that could also connect our veterans to support services that they're going to need ongoing. We also needed help with their financial situation. So if that's going to VBA or getting a fiduciary service, if that means they need to get in-home supportive services at their next placement, we needed to make sure those items were set up before they discharged from a shelter. And maybe we could help them apply for our California State Veterans Homes or even HUD-VASH. Maybe they could live independently if they just had some additional levels of service. So we also needed a program that was really connected to our local boarding care facilities and ongoing care homes. And we needed someone that could really provide ongoing intensive case management. We needed some behavior modifications. They've been coping for a long time with their current conditions, and if they're not getting better, we needed to make sure someone could provide education and that they were comfortable with working and with people that are experiencing homelessness. And definitely we needed to help with education, but advocacy and empowerment for the veteran when they're going to their doctor's appointment. All right, the next slide.
Do you want it to be on a different slide, Callista?
Yes, please. All right. So these are, it's okay. I think we may have missed one, but that's okay. So these are the results after we did our first year at our facility. We saw a decrease. We did a post 6 month comparison and then after discharge. So prior to their intervention of going into this new geriatric program, they were averaging about $127,000 a year for the people that we were in our study. And after we reduced that down to $59,000. Next slide. And we've also saw a large decrease in the utilization of emergency services, a reduction of 46%. I know from 2.2, that's 2.2 visits per month to 1.2 visits per month. May not seem like a lot, but it's 46% when we've got them consistently going into ERs and not being able to utilize other services that are available. It really is difficult for them to have consistent care. Next slide. And then overall, we saw a reduction in hospital stays of 48% reduction and an actual being admitted to the hospital, and a 14% in length of stay. So it's really a big difference for just having an additional hospital bed available for someone else, and also them not having to be chronically in the hospital. They're being able to be treated outside in a different type of setting. And these are all results that we are looking at that truly we're able to manage or see the outcomes quantitatively, but we really are excited to see the outcomes for the quality of life change. By ending the cycle of homelessness, the geriatric veterans are really becoming able to exist in an optimal level of independence. We're treating it with the right appropriate intervention, and we can give them dignity they deserve instead of being stuck in this consistent cycle of homelessness, street homelessness, jails, hospitals. So stability above all. Okay. And some of the things that are maybe different about our area before this is sent out to for adaption for others is the San Francisco Bay Area has outlying and its outlying communities really have difficulties with moderately priced housing, and that includes everything from long-term beds to short-term beds. I know I actually used to work with the same population in Dallas, and they were able to send out people from a hospital into a Medi-Cal or Medicaid pending bed. They didn't even have Medicaid yet, but we don't have that option where we're at. So your area may or may not face that challenge, but having an intervention for your geriatric veterans is going to be very important going forward. We're really seeing that increase. So even if it's just a few beds here or there that have a different intervention to really help them not become stuck in this cycle, it's going to be helpful for the veteran as they become more vulnerable. Also, one of the big things that we need to think about is these are shelter services. So our shelters can't provide licensed care. So what can we provide? Well, they can provide up to a one-person assist. They can provide education. They can provide extra support and medication management and reminders and proper food, right? So those are all things that are often done by an RCFE. However, RCFEs are licensed. So we have to be careful that we're not, as a shelter, providing licensed care. So sometimes it's easier to train a shelter staff to provide more care, or is it easier to have the RCFE provide less care? So that's something that you will have to know more about your community connections and engaging with your providers. I think some of our shelter providers would have had much more difficulty learning how to help someone with a one-person assist. Our shelters just really weren't set up for that kind of care. They've got way too many other things going on, but having an RCFE provider scale back the services that they normally provide so that we are in compliance with what a shelter can provide was really most beneficial, and that's the route that we took. And next, we just need to make sure that we're having lots of community connections. I think John really hit on that, but this is going to take all of us working together as a community to really help the oncoming silver tsunami. And I said oncoming, it's here. We're seeing it now. When we first started our shelter, we had it come from a 4-bed shelter. Now it's up to an 8-bed shelter, or could be up to an 8-bed shelter. So we're really working on expanding those services because we've seen this intervention really work. So that's what we're most excited about, is seeing the outcomes of veterans and seeing them in the cycle and go into an appropriate level of care.
Thank you, Callista. One clarification. I know we're holding questions, but an RFCE, what does that stand for?
It's a residential care facility.
Okay.
So that's something that there's a license for it that they can provide. RFCs can actually provide sometimes like 2-person assist, which what I mean by that is maybe they can actually help someone turn over in the bed or help do some of their ADLs personally for them. Our shelter staff aren't able to do that.
Okay, great. All right, well, so let's move on, and then I've got so many questions in my head, but we're gonna move on to Michael Blecker. Michael Blecker is the Executive Director of Swords to Plowshares, my boss. And he has been with Swords to Plowshares for over 40 years. He is an Army veteran, a Vietnam era veteran, a founding member of NCHV, and a terrific advocate for veterans. So take it away, Michael. Did you unmute yourself?
Got it. Okay. Thanks, Amy. So, okay, here we go. So this slide, you know, we could have a whole day of workshops on just what this slide is, right? It's about, you know, those in the military, particularly around the Vietnam War generation, who managed to endure, and that's the word, endure, that war and that experience, coming back and then facing pretty much neglect for many years. There was really no programs for them. And, you know, I could sort of pontificate on why that is, et cetera, but I'll just use the kind of the eyeball test and the fact that after 15 or 20 years after most of these veterans return or were separated into society, they were a significant portion of the homeless population. In San Francisco back in the mid 80s, they were like, you know, surveying those who were using some of the shelters, which at that time were really, you know, were faith-based shelters, Salvation Army, St. Vincent de Paul, Catholic Charities, et cetera. And the populations were primarily single adults, male single adults, right? And of that population, close to 40% had served in the military. And this was consistent with throughout the national urban scene. And in San Francisco, veterans were barely 11% of the general population, yet 40% of those using the shelters were in the military. And that just typifies, you know, this neglect and this situation that 20 years later in your mid 40s, you're homeless, right? And all that goes along with being homeless, right? It's not exactly a springboard to success, being homeless, and how difficult it has been to recover from that state and how that's grown. So by the early 90s, there was this, you know, there was an acknowledgement that we're close to 300,000 homeless vets, a significant portion, far over their representation, especially single male adults, had served in the military. Half of those veterans served during the Vietnam War. So those are extraordinary numbers. And that typifies, you know, all these other aspects: mental health, physical health, homelessness, community neglect, social isolation, unemployment. And I recall in 2010 when Eric Shinseki, who at that time was Secretary of the VA, and he talked about, he actually said we're going to eliminate veteran homelessness in 5 years, and really struck up a chord and fought for some of those important programs. But he used to say, he had a regular kind of speech, and he would say, our veterans lead the nation in homelessness, in mental health, in marital discord, in substance use, in social isolation. That was his standard rap, because veterans were leading the nation in those areas, especially senior veterans. So that's the population we're dealing with, but it just didn't happen. It wasn't just, wow, that happened. It happened because there was a complete neglect of their needs for the most important part of their readjustment. And again, we could talk and spend a long time going that. Could I have a next slide, please? So here's what we do at Swords. You know, we're in an urban area, San Francisco, Oakland, Bay Area, and we operate 420 units of housing. And there, anywhere, we opened this military base called the Veterans Academy on the Presidio for 108 units. We rehabbed a building using all kinds of dough that we could lay our hands on, and we opened that in 2012. And we master leased hotels, working closely with the city and county of San Francisco. And that's one of the quickest ways to build a program, to have housing, right? You have housing, and housing takes a long time to develop. For our new housing in Mission Bay, it took about 5 years, and tremendous challenges financially. Well, we can't wait 5 years, right? Especially for senior veterans. And in fact, an important aspect of the housing right now has been this push on the part of the VA to use the SSVF surge funding, to use the CARES Part 2 funding, to move money into the community for rental subsidies. So we can use the rental subsidies for emergency housing. And in San Francisco, which is a big urban area, that's meant single room occupancy hotels. And we have 150 veterans in those single occupancy hotels, in addition to the 421 units. And we did that because senior veterans are at grave risk with this virus, right? They're over 60, many of them. They have frailties, right? That Callista and John have both talked about. They're older than their years. They're very susceptible. they're going to die on the street and suffer unless they're moved quickly. So we can't wait to build 10,000 housing units. It's just in San Francisco, let alone New York and Los Angeles and Baltimore and all the big urban areas where there's significant populations of senior veterans as well as other veterans on the street. So we have, we have built up this housing, but it's taken a lot of years, right? And for us, one of the quickest models has been the master leasing model, where the city leases a hotel, the city engages you to operate, you being a nonprofit veteran organization, to operate that. You bring to the table rental subsidies, perhaps in the form of VASH, which is basically, what is VASH? It doesn't allow you to buy a house, but it does pay your rent, lifetime. And that's gold, right? That's gold, rental subsidy. And also you engage the city to use the continuum of care. That's part of, as John talks about, the whole community. It can't just be the VA. It has to, we have to access the entire community to get these rental subsidies, to move folks off the street. Just moving them off the street is going to make a difference in saving their lives or having them suffer, right? But as Callista and John both said, once they're off the street, they need all this other support, as you would expect. So also, we have this incredible racial disparity. Everyone should know that if you're doing this work, right? African Americans are like 8% or 6% of the population, but 40% of the homeless population in San Francisco. Outrageous disparities, right? So we know that. Can I have the next slide, please? So your work that you're doing is addressing racial justice as well when you're taking veterans off the street. Keep that in mind. So we did these, trying to learn what we do. We have, we have a lot of vets. We have 400, almost 500 vets that we're working with, right? So we try to figure out what their needs might be. What do they want? So we did these staff listening sessions, not even, listen to the vets, but also listen to our field staff as well. And, this whole litany of issues that are not unfamiliar with anyone who's run a program, right? Assistance with ADLs, medication management, which is a real key, of course, because so many veterans have multiple issues, right? It's not unusual to see someone with, chronic pulmonary respiratory issues, as well as neuropathy and diabetes, as well as substance use, as well as, other issues, right? Pain. Let's just take physical pain. Older vets have lots of physical pain issues, right? They take medications and they have a series of medications, and that's an issue of their ability to manage it. I think Callista talks about medication reminders. Well, it's not so easy when you're running if you have a hotel, it's a single room occupancy hotel. They're all tenants in the hotel. You can't bang on the door and demand what they're doing. So what you have to do is work with them, health aware, health checks, try to provide meals, try to engage them. And I'll get into that more with the issues. So these things are not, of course, these are like, yeah, I would expect this to happen. Could I have the next slide, please? So this is something, this in-home support services, right? This is the major support base for seniors and disabled. In-home support services. This is where all that Medi-Cal money goes by and large. And that understanding of that system of care is very important, i.e. how does the Medicaid, Medicare, Medi-Cal model impact the VA? Or how does veterans get their fair share of that resource? And so if you're providing services and you're able to operate a hotel, let's say, in an urban area, what kind of staff do you need? And what kind of supports do you need? And as we know, in-home supports are, sort of somebody coming in and taking care of the needs and helping the veteran attend to the cleaning and the laundry and helping them with transportation needs and helping them do grocery shopping. Of course they need that. Don't all of our families need that? Older families, do they want that? They need that. But in-home supports are not so easy to access if you're a veteran, and there's a very high threshold, income threshold, and if you don't meet that income threshold, then you have to pay for a share of the cost, and this could be very expensive. And most veterans who are just barely making it with Social Security or pension or perhaps service-connected disability, their income is exceedingly low, right? They're loath to take a portion of that and pay for an in-home, their share of costs for in-home support services. So that's been a real problem. But we're all talking about getting adequate coverage here, engaging veterans. And so those are the challenges, trying to work with that larger system of care, and how do you get more help for what you can do at that hotel or what you can do in your housing setting. And I'm not talking about VASH. Let's assume there's VASH caseworkers there. But of course, the problem is they don't work in the evening. They're not working on weekends. They need more than that. They need more than 4 VASH caseworkers for 130 veterans who have significant issues, right? You're desperate for coverage. You're desperate to engage people, because that's how you're going to alleviate their suffering, by engaging them, making sure that they're eating well, making sure their dental needs are taken care of, making sure they get into their health care, they're making their appointments. And I'll talk more about that. But I think it's very important for this system, those who are working with it, to understand the larger system, the Medicare system. It's very significant, because veterans should get their fair share of those resources. And they tend not to identify veterans in those systems of care. And that's, I think, a battle we should take on. Can I have the next slide, please? So this is sort of to piggyback on the presentation we just heard of. The model is great, of course. I have no qualms with the wonderful model, but of course it needs to be brought up to some significant scale. Some significant scale. We're dealing with thousands of veterans in these urban areas. We can't have just a few beds here and there. It's a drop in the bucket. So that's the first thing. And I think there's some good examples, including besides the Palo Alto program, there's a recent program in the Veterans Village of Coma that I thought was good, because that has about 60 veterans in that program, but it also has augmented staff. I think they have a full-time nurse, so it's 65 veterans. They have a and besides VASH, right? Besides 3 VASH case managers, they have a full-time nurse, a half-time psychiatric nurse practitioner, and a part-time geriatrician. So that's just to give you a sense of what's needed, to give you besides the case management, people need nursing care, and they need it located in the building if they can get it. I'll give you, let's see, well, let me just tell you about one example we had in the Stanford Hotel, where it's again, a master lease hotel. It's 135 veterans, right, in this hotel. And it's, 9-story hotel. It's, a relatively well-made, well-done hotel, but it was, the rooms are real small, right? But folks have their restrooms, they have bathrooms in the hotel, in their room. And they have a little area where they can cook and all that, but it's very small, and there's not a lot of common space in that hotel. And so there's a desperate need to get nursing support, because we have 3 VASH case managers in that for 135 gravely disabled veterans. And the only reason we got to operate that program was because the city was really keen on taking the most disabled folks, veterans, right off the street, because that's what their interest was. So we had veterans who scored very highly in these vulnerability indexes, who have these range of issues. And there's 135 of them, and we have 3 or maybe 4 VASH case managers. And we were crawling up the wall. We had our desk monitors, but we knew these veterans, to have any chance to support them and to alleviate their suffering, we needed staff. We needed that interaction. And so we actually developed some data that showed that some of these veterans were seeking emergency room care. So they were going to the emergency room, yet even though they were eligible for VA care, they did not have a primary care physician. They were using emergency rooms. They didn't have a primary care physician, even though they were eligible for VA healthcare. So we created that data, and really the VASH team created that data. And as a result of that, they gave us really a nurse, right? We have a nurse there. we have a little more support, but we had to fight to get that. We had to demonstrate by the data that it was more cost, the cost savings were greater by having this staff support. Could I have a next slide, please? So a lot of this again is and I think I'm going over my time here, but I'll just say that I agree that we could use, we desperately need support staff besides VASH case managers, right? We need that nursing care, right? And we need that, and we need staff to do basic things like provide transportation, help with grocery shopping, pay attention to folks, help them break out of their isolation. Those are just, this is not, rocket science. This is just what you would think folks would need. And that's what we need to do. That's what we need who are like in the middle of it. And I know many of you out there are in the middle of it. That's all I have. Thank you.
All right. Fantastic. Thank you all. We do have a lot of questions here. I'm going to start with just some very practical ones. So one for Callista about how your program was funded.
Sure, it's actually an emergency shelter contract through SERS, so it's VA funded. Those SERS contracts are normally a 60-day program, and then there can be additional ones after that. But we actually expect for this contract for them to be there longer than 60 days to really get stabilized.
Okay.
I'll just add briefly, if I could, we have 6 different sites for our, close to 400 units, and each site is like different, right? But I think the commonality is the VASH case managers and the rental subsidies that are funded. But we've also used the continuum of care vouchers that have come through the mainstream HUD McKinney dollars, right? So we access that, and we try to put our hands on any dough for services. Services are the hardest thing to fund, by the way.
Yes. We have a question from Dan Thomas saying that some housing authorities don't allow master leases to use vouchers. Do any of you have any suggestions to overcome this or experience with that? It's a housing authority, I would assume.
We don't have a problem. I can't imagine how this would be done without, I mean, most of the urban areas use, single room occupancy hotels and leases. That's the common way to, make housing available.
Yeah, I mean, all I can say is that, I mean, it's getting federal dollars into the local system of care. So, perhaps going to your Congress people and trying to overcome that. But we haven't come up against that. I have a question here that, comments also about how unique this population is, but that the stand downs have been canceled because of COVID. Of course, that's also impacted a lot of our other work. So how has that impacted in San Diego and your work, John?
Well, actually, we are going to have a stand down in November. It's going to be a one-day event, and we're trying to target as much as possible towards our older veterans. We're going to bring the services that we can. We're going to have things that we give, and it's going to be all plastic wrapped and so on and so forth. Social distancing, masks, everything that we need to do, but we're going to try and keep it going. The idea of doing it one day, again, is to reduce the amount of exposure that people have.
Okay. We have another question from Amanda Dobbs asking if there's any suggestions about working in rural environments where there's limited to no funding. There are not even enough long-term care facilities to support otherwise housed aging population, and most shelters will not accept anyone with medical equipment, issues with ambulation, etc. Does anyone have any comments on that issue?
I think my comment would be, that you're right, things are not working. And just adding a few more beds, you know, here and there is just not going to do it. And I think that we as a country really have to come together and look at this problem and not look for stopgap measures, but somehow find a way to bring this to a national agenda to be able to make this right. There's no good answer for somebody in a rural community where there's no access to services. So I don't know what other people's thoughts are, but that's mine, is that this needs to be a wake-up call for all of us.
Also, I would say it's not limited to rural communities. In the San Francisco Bay Area, board and cares have all but disappeared. Long-term care facilities are hard to come by. They're expensive. They're hard to navigate. So this is an issue, everywhere. One of the things I want to bring up is, sort of making the most of what resources we have. And there's so many systems and licensures and the importance that I see of having more staffing and services in the venue where the veterans are, and what kind of services could be delivered quickly, meaning, without a lot of licensure, and creating that community. Do you have any comments about developing resources for those kinds of services?
I would just say there was that frail and elderly program the VA had that acknowledged that there was for certain populations, in this case, to augment those populations with other staff, like a CNA, right, certified nursing assistant, or with some, just some assistance in addition to the standard, the recognition that that was at least a start. But I think that's been unfunded.
Yeah. Marilyn Darling has a question about how we can get the veterans' family members involved. Callista, do you have any comments on that?
Yeah, it's, we can't force family members to become involved, but sometimes if we can repair relationships, I know there's a lot of talk about diversion and things like that, and one of those first things to do is to start calling people, and maybe they haven't been able to find someone for a long period of time, or maybe we're able to make that bridge that they haven't been talking to, someone for 10 years or something like that. So just I get the intensive case management portion that each person needs is so diverse that it can really help if we can get them in. I know on one of the examples that I had, we had the veteran that came in that hadn't talked to his family in 10 years. And by the end, they were at least helping make decisions. So they were supportive. They couldn't take him into their home, but they could help him make decisions and really just starting those relationships again. So it's having the staff again to really step in and advocate on behalf of the veteran.
Okay. Anyone else have comment on that? Alicia Herman has a question. Does anyone's program use a staggered shift so there's greater coverage throughout the day for head VASH social workers or social work assistants beyond business hours?
The shelter has 24-hour coverage. There's always someone there, multiple people on staff.
Well, I think, with our housing, there's always people on staff, but not necessarily, the HUD VASH case managers or VA employees, and they have, business hours, which I think, the program monitors, they're the ones, even though they're not licensed or professional, they're the ones who see people coming in and out the doors, or more importantly, not seeing people coming in and out of the doors. So it's really important, I think, to have the property management and those folks to, be monitoring, to be taking notes on their shifts. And then in the morning, when the clinicians come in, they can communicate. I haven't seen this veteran in a long time, or someone appeared to be having difficulty. We don't want to check on them. So that's one way to try and overcome those issues with the hours, by having staff there responsive. We have another question. Oh, wait a minute. Let me just find it here. I'm sorry. Michael and John addressed this a little bit, but there's a question about how people become homeless. So, if we talk about prevention, I'm trying to find that question here. Marilyn Darling, my question would be, how and why did they become homeless? Wouldn't it be pertinent to establish programs at separation and reentry to civilian life? John, do you have comments on that?
Well, I think there are a lot of reasons. Am I muted? No.
No.
Okay. Can you hear me?
Yeah.
Okay. I think there's a disconnect between active duty military and civilian life. When you're on active duty, everything is taken care of for you. Your clothing, your health needs, anything that you need is there and it's provided. And your support system, your status, everything is part of being in the military. And then one day you ETS and it's gone, and you're suddenly, without anything, without a job, without a wardrobe. And some people who have a good support system are able to make the transition. Fortunately, most folks do, and into civilian life. Some don't. Some just find themselves homeless. So I know that's one reason that we see a lot of veteran homelessness, and that disconnect. And, for me, I think that there really ought to be more coordination between active duty military and VA. I think that those two organizations really need to be speaking with each other and making sure that as a person is beginning to transition out of the military, they really are prepared for the civilian life.
Okay, we are coming up against the hour. One thing I want to comment on quickly is, bringing in the mainstream dollars. And I don't know, Michael, if you really got into the Dignity Fund, but we were able to get some funding through sort of mainstream non-veteran aging dollars out of the Office on Aging and through our local Department of Aging and Adult Services through a proposition. So it was put to the voters. And the proposition was looking for added funding for different underserved communities, including LGBT and veterans. And this passed, and that is actually funded some additional staffing in our housing. So that's one tactic that people might try in your community to get some more funding in order to hire staff to engage with these veterans. And we all have to be really active in trying to figure out how to respond quickly, because as Michael and John and Callista says, we can't wait. These people are in duress right now. And every minute they're on the streets is a threat. So with that, I just want to very quickly give you an opportunity for closing words. We'll start with Callista. Oh, you're muted.
Just to reiterate that each of these veterans really did serve for us, and the dignity that we should be able to provide them as they're aging is something that we're missing. And any of us that can advocate, if you have someone's ear, call a congressman, do what you can to get more funding out there for everyone.
John?
Yeah, I think what I want to tell people is don't underestimate the power that you have potentially as a leader. I mean, a lot of the questions that are coming up there's no answer for them because there's nothing, we have no resources. What I want to recommend is that take a stand, bring people together in your community, bring together members of veteran organizations, formerly homeless veterans, politicians, media, anybody, healthcare providers, bring them all together in one room and say, look, here's the problems we're having in our community, and we need to figure out a way to do something with what we have. And I think as that starts happening around the country, I think that the change is going to be made. I think it has to happen at this grassroots effort. Michael did a great job, I think, at really letting us know, how overwhelming this is in terms of trying to solve the problems that are there, because their problems are legion and the resources that we have are just not adequate. But be a leader, pull people together, and you'll be amazed at what powerful things can happen in your community.
Thank you, wonderful. And Michael.
Yeah, I guess I want to just echo John and also say that we really need to preserve the public system of care that we have, which is, we can't take it for granted. The VA needs to be fully funded. They have thousands of physicians that are not filled. They have thousands of a tremendous need for the VA to be fully funded. And we need to make sure that VA doesn't become privatized, right? And it doesn't just become another private health insurance process. So that's for one. And the other thing is we just have to fight for our public systems of care. There's been all this stuff that's sort of under the radar, but what it does, it raises the bar. So it makes it more difficult to secure these things, or they add another bureaucratic process that will, by nature, and they know this, will discourage people from applying. So we really have to protect our system of care.
Absolutely, and strengthen it. And I just, John and Michael, some of what you're saying about, just get out there and do it. I mean, we owe so much to you and your colleagues, who saw these problems and have been working on it for so many years. And then Callista doing innovative things from within the VA, which, delivers excellent geriatric care. We just need a whole lot more of it. Cindy, if our NCHV hosts are back there behind the curtain, I don't know that there's if we can go on or close out is actually after 11 o'clock. Are you there?
Yeah, so yes, I am here, Amy. I just wanted to thank all four of you. I think this session has been fantastic. As Amy can see, because we've been following her questions, there are still quite a few questions that have come in. What I'd like to propose is we're going to copy the questions that weren't answered and we'll circulate them to our experts. And we're going to try and get some additional answers for folks, just knowing that people do have schedules that they like to keep to. And while this is a fantastic conversation, we didn't ask our presenters to stay late. So we do have those extra questions, though. We appreciate all of the time from all four of you today, and we will gather them up, and eventually the recording for the session will be available tomorrow, but the slides and then the questions will be available shortly after the conference ends. So give us a few days after this week to sort of gather everything together, but we will have, we'll try to get some more answers. And again, thank all four of you for the time this morning for all of you, and this afternoon or this morning for attendees, depending on where everyone is. Thank you so much.
Thank you.
Michael. Michael, take care, brother. You're muted.
All right, you take care, John, too.
Yeah, thanks.
Can you hear me?
Yes.
You're
Yeah,
kind of frozen. Okay, there you go.
Okay.
Wow. So
we're not,
it would be good to keep connected, right? To stay engaged.
yeah,
Really.
definitely.
And I know, with Robert is, and I don't know how, I'm trying to think of, the founder of VBSD, what is his name? The founder of VBSD?
Jack Lyon.
Jack Lyon. How is Jack? Is he still around?
Jack is he's still around. He had like quadruple bypass surgery. So he's really slowed down, but he actually works with a lot of returning Marines.
Oh yeah, he loves that.
Yeah. And
yeah, he really loves that.
yeah, no, he's a great friend.
Yeah, good. Okay.
All right.
You, John, you take care.
Yeah, so maybe NCHV could have some sort of group or something, to kind of look into this. I mean, I'm not sure how it works, but I think, I'm hoping to see some sort of national thing start to go. I mean, I just want to spill it and get out of the way, basically.
Andre, doesn't he sit on the advisory committee for homeless vets, the secretary's committee, I think?
He does. He's on the board of NCHV, I know. But,
Yeah. I think he's also on the advisory committee, which might be the way to keep this issue strong to the advisory, demanding attention and, using that platform, right?
I'll definitely check with Andre.
Within the VA, yeah, I would do. And who's the new VBSD ED?
I forgot her name and I haven't met her yet. That just happened.
Kim is left, right? Kim is left.
Kim is gone, yeah.
Yeah. Okay, all right. So, we're involved with, CASVA, right? Even though Peter's no longer around, but
Peter.
Yeah. I had a dream about Jack McCluskey yesterday, by the way.
Really?
Yeah, I did, yeah. It's hilarious. But he was
I just remember Pete Cameron coming to an early stand down in Bermuda shorts and black socks up to his knees. And it's like, it was Peter, he was just
that's
a great guy.
Yeah, right. Yeah. We'll forgive Peter for practically anything. That's all I can say.
Absolutely. Okay, brother. Take care of yourself.
You too, John. Okay.
All right.
Bye.